Okay, so I'd like to introduce Dr. Jim Froehlich, who is the Director of Vascular Medicine and the Melvin A. Lester, MD, Professor of Cardiovascular Medicine. As many of you know, the FMD site that manages all of our data is at the University of Michigan under Dr. Froehlich's supervision, and he's going to talk to us or give us an update on the North American Registry, current state, and future plans. Jim?
Thanks, Jeff. Can everybody see my slides and hear me?
I can hear you, Jim, and I can see your slides.
Okay, excellent.
There,
Thanks.
Jim?
Yep. So you've been hearing a lot about the registry already and the work of the registry. What I wanted to do is
Your
kind of
slides are
give,
there.
can you hear me?
I can hear you just fine, Jim, and I can see your slides.
Okay,
I
good.
don't know where Dr. Froehlich went.
All right.
Okay.
So I'm going to go ahead. So what I wanted to do, and I wanted to leave time for questions, so I'll try to be brief and give people some background as to what the registry is. I know that a lot of you are very familiar with the registry and its work, but I wanted to make sure everybody was up to speed. So, and I think I can advance slides. Let's see. So what is a registry? Not to get too basic, but just so we all understand what we're talking about. Registry science means basically collecting as much information as you can about people who have a disease or problem. It's ideally suited to studying rare diseases. In the past, medicine was based on a physician's experience in centuries past. And the more experience you had, the smarter you were. And we're way beyond that now with common diseases, but with rare diseases or uncommon diseases like FMD, no one center can see enough to learn as much as we can. So basically a registry is an attempt to pool our, excuse me, our information and study epidemiology or the patterns of disease. And as I said, it's ideal for studying rare disorders, but it's practice-based. It's not a study of a clinical trial. It's not a study of a treatment. It's not a study of a test. It's more about looking at the patterns of care, and it can be used for determining whether appropriate care is happening or whether care can be, the quality of care can be improved. The other side benefit of a registry like this is you build a network of investigators, and you've already heard that registry centers are people who have an interest in this and get to collaborate with other registry centers. And that leads to other side projects like the genetics you're going to learn about or hear about later on this afternoon, and genetic registries. It's important to remember, and this has already been covered today by Dr. Olin and others, what we learn from a registry is an observation. It's not a study, it's a hypothesis. It's not a test of a hypothesis, it's a hypothesis generating exercise. So you've heard him say that we now know that FMD is associated with aneurysms in the brain. And all we can say from the registry is that's a clear association. We are learning a lot about the natural history disease, and a lot of what's already been discussed today are things that we have learned from the registry, and we can also track outcomes and see how people do. And from this, we've learned, for example, that to an astonishing degree, dissections heal. And that helps us also identify groups of patients for further study, especially genetic study. Phenotypes means someone's clinical situation. So we have people, we meet patients who have FMD with aneurysms, and we meet patients with FMD with no aneurysms. So that's a phenotype difference. And of course, the geneticists are wondering, can we figure out what the genetic reason for that is? And one of the key ways to do that, you're going to hear more about this afternoon, is putting to a registry of patients and patient clinical information together with genetic material or a biobank, and put together the clinical observations or phenotypes with genetic observations or gene discovery. And you'll hear a lot more about that. And of course, as I said, it has allowed us to build a group of collaborators and a research team. So all of this work is owed to the Fibromuscular Disease Society of America. And that is the work of Pam Mace and Pam Mace and Pam Mace. And I can't, obviously a lot of people have put a lot of effort into the Fibromuscular Disease Society of America and its work, and they sponsor this registry, as you know, but her drive is extraordinary and is really responsible for pushing all of us to do more. As I said, FMDSA sponsors the registry. Just by way of history, we started in 2009, and we've had periods of high productivity and periods of just slogging away trying to do the work. Sponsored by FMD Society of America, again, to look at the epidemiology. And the registry has expanded now to 21 sites. And the first publication from the registry itself was in 2012. There's been a lot more since. I'm not going to go into too much detail about what the publications have shown, but you've already seen these. Oops, I want to go back. The initial publication that Jeff Olin and Heather Gornick really commandeered and made these seminal observations, and then subsequently Dr. Olin's group looked at the aneurysms, and you saw these data earlier today. The point being that these numbers and these associations come from the registry, basically, come from our ability to collect enough patients to be able to say, yes, patients who have FMD have more aneurysms in their brain than the average population. This is a paper that specifically asked that question that one of our medical students at the University of Michigan did a lot of the work on, and showed that there's this association, as you can see outlined in red, between having FMD and having an intracranial aneurysm. And so from these observations, from these associations, we can now say, you should have a CAT scan or an MR of your brain if you have FMD to make sure you don't have brain aneurysm, because we've seen it pretty frequently. So basically, a whole bunch of papers have come from this registry, and I'm not going to go into the details of all of these papers, but basically looking at things like how frequent are headaches, how frequent is pulsatile tinnitus, how do elderly patients do who are discovered to have FMD when they're old, which now unfortunately means people like me. And oops, I skipped one, but there are a whole bunch looking at racial differences, looking at antiplatelet therapy, sex differences, pediatric versus adults, the association with smoking. So these are the types of things, and as the registry grows, we can look at this more and more. For example, the sex study, there's so few men with FMD that we really couldn't comment on that until the registry got to a certain size. This is a very long list that actually Dr. Gornick put together a few years ago, but it shows how what we now know came from observations in the registry. The type of symptoms that people with FMD have, headaches and pulsatile tinnitus. The fact that it's just as common in the neck arteries as it is in the renal arteries. The fact that significant proportion can go on to have dissection, and that 13% have brain aneurysms. So I didn't want to go through this in too much detail. A lot of this you all know, because we have tried very hard to share what we've learned and what we've observed, and has now become pretty well established as guidance for how we can advise patients who have FMD. Before 2010 or 2012, these things weren't known. And I think I've said it before publicly, I'll say it again. Dr. Olin and Dr. Gornick are really exceptional clinician scientists. And it takes an incredibly strong and directed seeker of the truth like Dr. Olin to be able to say, we've learned so much from this registry that proves that my papers before 2005 were wrong, which is an incredible accomplishment, in my opinion. So here's where we're going now in terms of the database. We've managed to increase the number of centers up to 21. We're knocking at the door of 5,000 patients enrolled in our registry and 14,000 follow-ups. So in terms of some of the things we have done in the last year is we're lining up some new publications. Two are basically reaching their final stages. I will tell you that a lot of this is on hold for the past few months because we are working to reanalyze and establish the quality of the data. We've established new mechanisms for checking data quality and giving report cards back to each site. MCORRP, the group that I helped to run, runs several registries, and this is something we're trying to do with each registry so that every site can get a good handle on the quality of their data. And we also work with sites to help train abstractors and coordinators. We've also got a more rigorous process for adding new variables to the database. Excuse me. And we've also established new committees that have regular meetings now, an operations committee as well as a publication committee and the standing steering committee. So a lot of this restructuring has led to increased rigor. And so at this point, excuse me, sorry. We are going through a pretty rigorous data quality review, which is going to take probably a few more months before we can put the final touches on several manuscripts. I hate to make predictions, but we have 4 manuscripts that could possibly be out in the next 6 to 12 months. But the process of data analytics and data cleaning is always difficult to predict. One of our goals in terms of clinical activity within the registry, excuse me, is to improve the thoroughness of imaging and get imaging rates as high as we can. And we'll probably, by the end of the year, reach 5,000 patients enrolled. So this is what our current registry map looks like. We've got centers all across the United States and into Canada, which is why we're now calling ourselves the North American Registry. And so again, things that we now take for granted that came from the registry, some highlights. The fact that we now think of it as focal and multifocal. We currently think of FMD as a multi-vessel problem. The association with SCAD didn't come from our registry, but it certainly came from interest in the underlying causes of SCAD. And you're about to hear more from Dr. Kim about the SCAD registry. Oops, sorry. The association with intracranial aneurysms, the first consensus statement. And as I said, we've expanded involvement with more sites and more committees and these are the 4 standing committees currently that meet regularly. So basically, Dr. Charcot is an historic medical scientist of centuries past, and he made the observation, there's nothing new about disease. It's we who have changed as we start to recognize what was formerly imperceptible. And that process is accomplished by registries like this. So as you have heard, MCORRP is the organization I help to run. These are the directors of MCORRP, but the real work is done by these people. These are our team at MCORRP, and the ones I want to highlight that are specifically involved in FMD are Rachel Krallman, who heads up our FMD program, Xiaoqui Gu, who's a programmer and statistician who's done incredible work with this registry. Both of our programmers, Scott Ash and Brian Shensky, have been involved as well. And Brian Haymart, who really herds all the cats and helps to run MCORRP. So I'm going to stop there